Great. So we're both going to be speaking about some of these topics. And so I'm Pat Culligan, and we worked it out. So I was going to start. And so this is just a discussion about treatment and prevention of urinary incontinence and pelvic organ prolapse. And we are urogynecologists. We treat women with pelvic floor disorders. We're located in Ridgewood, and that's our building, and that's us. Urogynecology is it's not really fair to call it a new subspecialty anymore. It's been around for a while, but it's really sort of a recognition that there's overlap between some aspects of urology and some aspects of gynecology, and that's why our field exists. And we treat disorders of the female pelvic floor, such as pelvic organ prolapse, urinary incontinence, overactive bladder, that type of thing. One of the first questions I get asked is how does this happen? And pregnancy and vaginal deliveries are really the main causes of a lot of female pelvic floor disorders. And there's really an epidemic. The average woman has a 30% chance of needing surgery to correct either prolapse or incontinence in her lifetime. So if you haven't heard your friends talking about this problem, it's maybe because they're keeping it private, but it's not because it's not happening. So what are the female pelvic organs? There's the uterus, the bladder, urethra shown here, vagina, and the rectum. And then the next slide over, the next part of the slide shows the pelvic floor muscles, which provides support to all of the organs and sort of keeps them functioning separate from one another. Next slide. Without the muscles, you just have this connective tissue, which sort of tethers things in place. It's very important, but it's not as important as the muscle groups that you can see here. The first vaginal delivery is usually the one that provides the kind of the most damage if it's going to happen. However, every subsequent delivery can provide more damage to the pelvic floor, and it especially affects people who are having babies relatively close together. So the damage that's sustained during childbirth makes it sometimes hard to recover those muscles. One of the ways you can prevent that is to do these Kegel exercises. So if you watch this little animation, it's got two views of the pelvic floor muscles. Some people don't, is it playing on yours? Yeah, there we go. Oh, can you go back, Cristina? It's got two views of the female pelvic floor muscles. And if you're watching this little video play, you'll see the muscles contract in these two dimensions. So you can sort of think about how the muscles work when you're actually working on the Kegel muscles. And the proper way to do a Kegel exercise squeeze would be to hold for 5 or 10 seconds if possible and relax. And it gets kind of tiring. You do it again. And a set of 10 3 times a day would be a way to prevent and treat many of the things that we see. And now we're going to turn it over to Cristina to talk about urinary incontinence.
Hi, good evening, everyone. So our topic today is about urinary incontinence and pelvic organ prolapse. I want to clarify first that even though vaginal deliveries is a big contribution or contributory factor to developing these issues, it doesn't mean that we're in any way saying that we think that everybody should have a C-section, because that definitely has other, consequences. We see a lot of women who actually, just by the fact of carrying a baby to term, even if they have a C-section, they also develop pelvic floor disorders. So I just wanted to make that point clear, that there's also genetic factors, like if it tends to run in your family, you're more likely to develop this. There are things that contribute to the pelvic floor disorders, like if you're constipated, if you have a job that involves a lot of heavy lifting, if you are overweight. So it's not only about vaginal deliveries, but definitely vaginal deliveries have a big impact on the pelvic floor.
Absolutely.
So when we talk about urinary incontinence, there's always the question about, why is that is so common? And when you see this aisle, I'm sure it looks very familiar to a lot of you, because who thought that once we're done with having our periods, we're going to go back to that aisle to find pads for incontinence? So it's a very unspoken epidemic. I think a lot of women suffer with this, but not everyone feels comfortable talking to their doctors about it or sharing it with some friends. It's embarrassing. It has a lot of aspects that make women feel very shy about talking about incontinence. Now, when I say incontinence, I am talking about any leakage of urine, regardless of the amount. It could be a dribble, it could be a splash, it could be a lot of urine. Because some of my patients think that when we say incontinence, we mean like, oh, like everything is, soaking. No, it could be a small amount of urine. It doesn't have to be every single day, but we still will say that's an incontinence. So there are three different kinds, because not all incontinence happens for the same conditions. And this is a little bit hard to understand sometimes. Patients may have heard, oh, my neighbor had a medication for incontinence, or my other friend had a surgery for incontinence. Can I have that? So it all depends on what type of incontinence do you have. And a lot of times people tend to have a mix of different types. So the management and the tailoring of the treatment depends on, each component of the incontinence. So we're going to talk about one of the ones that I see a lot. It's the overactive bladder. So this would be the patient that typically says, I have to go to the bathroom constantly. I just feel like my bladder is never empty. I wake up at night. And then the key is that if they try to postpone going to the bathroom, they have a really intense urgency to urinate, and then they lose control. So basically, the common complaint is like, I don't make it to the bathroom in time. I try to get there, and as I'm going to the restroom, put the keys in the door, or maybe I'm washing the dishes, water is running, and right away I just need to go to the bathroom and I don't make it. So that is due to an overactive bladder, which has to do with, actually is not a drop bladder, as some people may think of, is a situation where the functioning of the bladder is not good. So the nerves that control the bladder control starts in our brains, go down the spine into the bladder. That connection and that communication between the bladder and our brain is not good. Why? Getting old. Basically, that's the most common answer. So how can we make that functioning of that bladder better? So when you see here dietary changes, what I mean by that, if you're eating, not so much eating, if you're drinking anything that is acidic, that coffee that you love so much, the tea, the carbonation, the juices, the alcohol, that is going to exacerbate the leaking of urine, because it's going to make it so that you have more urgency to go. Then I tell the patients that the next step will be to try and retrain your bladder. What do I mean by that? So when you feel that urge and starts to grow, what do typically patients do? They run to the bathroom, right? They feel the urge, they just run to the bathroom. And that is not a good thing, because then you're enabling the process. What you want to do instead is, when you feel the urge, you want to stop what you're doing and then take a few seconds to squeeze those pelvic floor muscles, like what Dr. Culligan was saying. You try to squeeze those do those Kegel contractions 5 times really quickly, but it's not about doing them randomly. It's about doing them when you're feeling the urge. And then you want to take a slow, deep breath, distract yourself, don't think about the restroom, and then repeat this cycle of squeezing and distracting yourself until the urgency starts to subside. And you're going to see how that's actually very helpful in a lot of situations. Not always, but it is helpful. And then you want to slowly walk towards the restroom. You don't want to rush into that restroom. There's also medications that we use for overactive bladder. You may have seen now, there's a lot of commercials on Gemtesa. I'm sure you've seen the commercials on TV. That's the newest medications. It's a pill that you take, and there's different ones. They do have some side effects, but they're pretty well tolerable. I would say most patients do well on them. And then there's things that we do when everything else fails. You may have heard a friend say, I got a Botox injection for my bladder, or I have a pacemaker for my bladder. So there's a lot of that as well. we're gonna ask that patients type questions under the chat, and at the end of the presentation, or maybe in between, we're gonna be answering some of these questions. Now, this diagram that we have here is trying to illustrate what we call stress urinary incontinence. So this is the other main type of leakage, and this is very different. This will be when the patient says, oh, if I have a cough, if I'm laughing, if I try to exercise, forget about it. I'm gonna go into the gym with black pants so that if I leak, nobody knows. I can't go to a dance. I'm worried about going to a wedding if there's a lot of dancing, because at the moment I put any pressure down on the bladder, I'm gonna be leaking. So that is very different to I have to urinate and I can't make it there. So when we talk about this other type of leaking, the one we're gonna call that stress incontinence, even though it doesn't have to do anything with mental stress, but it does have to do with a stress or pressure down on the pelvic floor, there's different treatments. And one of them is to do pelvic floor exercises to strengthen the pelvic floor. I do refer a lot of patients for something that most patients are surprised to hear that it even exists. It's called pelvic floor physical therapy. And yes, there is a specialist in the physical therapy department that deals with the pelvic floor, and she will teach you how to do these exercises, how to retrain the bladder, and is very helpful. When we're talking about the stress urinary incontinence, if the pelvic floor exercises are not enough, we have procedures. I mean, there are some things that you can place inside the vagina called vaginal pessary for incontinence. I wouldn't say that's the most popular option. And then there's procedures. Most of the procedures that we have are pretty simple. They don't require a major surgery. There's things that we do in the office that I'm going to explain in a little bit. And then there's the classic sling, which is a 20-minute outpatient surgery. The recovery is not bad at all. It's only 20 minutes under anesthesia. And what we do is we place through a vaginal incision that measures about 1 centimeter, we will be placing something to strengthen the urethra. The urethra is the little tube where the urine comes out, so that you can go back to dancing and exercising and doing all these things without having to worry about it. Now, this video here shows one of the procedures we do in the office. It's called a urethral bulking. Imagine if you inject a filler into that urethra. So as you see in the picture, we're using a very small needle, and this is not in the office under local anesthesia, where we're injecting a filler to make that urethra a little bit narrower, so that if the tube itself is narrower, it's going to seal better. So if you're coughing, laughing, sneezing, jumping, you're gonna notice a difference right away. I'm gonna now have Dr. Culligan move on with the next part of the presentation. I'm just checking the questions, and I don't see anything so far related exactly to incontinence. So we're gonna move on with prolapse, and then at the end, we'll take some questions.
Thank you. Yeah. So pelvic organ prolapse and urinary incontinence exist sort of on a spectrum. They're similar causes for each. You noticed in the picture of the stress incontinence issue that there was some laxity or some extra movement around the urethra happening, and when you multiply that out a little bit further, or have a little more damage, or the muscles are a little bit weaker, then you can develop prolapse. The very most important rule about prolapse is, if it's not bothering you, you shouldn't bother it. In other words, if a patient comes to me and somebody's told them, let's say a gynecologist was examining them and said, it looks like your bladder's dropping, but the patient had no idea that that was happening, and they didn't experience any quality of life issues at all and didn't even know, there's no way that I'm going to be suggesting any sort of treatment for that. We might measure it. We might measure it in the future. Let's go back, please. You might measure it in the future, but that would be a situation like in this image here. We've got on the one side of the screen, you can see normal, and then the other side, a little bit of relaxation. When someone has a little bit of a dropped bladder, it doesn't tend to give symptoms. And so if it's not bothering the patient, we're not going to be suggesting any treatments other than maybe prevention through Kegel exercises. Next slide. So what are prolapse symptoms? A heavy bulging pressure sensation, where something's bulging out, maybe rubbing on the clothes or feeling like you're sitting on a ball, or an actual bulge coming out beyond the opening of the vagina, the size of a walnut, or bigger like an egg, or bigger like a lemon, or sometimes even as big as a grapefruit. I operated on somebody like that this week. Not pain though. You can notice I didn't really mention pain, and that's because pain and prolapse don't typically go together. If a patient wants a non-surgical management of prolapse, then a pessary is a tried and true answer. There's usually a pessary that we can find that will help someone with prolapse, and it's a quality of life enhancer, and it's just a choice. Lots of people will look at pessaries and think, well, wow, that's wonderful that there's something that I can try. I make the analogy of, it compares to sort of like if you went to an orthopedic surgeon and the surgeon offered you a knee surgery or a knee brace, and you chose to use the knee brace. That would be sort of like choosing a pessary. And so we pretty much offer everybody that we see who wants treatment for prolapse a pessary first. And here's how it works. Most people can learn how to put the pessary in and take it out themselves so that they can really manage these things themselves. And it can be a great way to treat prolapse without going to the operating room. Now, what are the types of prolapse? Cystocele is when the bladder is bulging down. So if you toggle back and forth on this slide, it'll sort of show, here's normal anatomy with the bladder in front and the uterus there and the rectum. And the cystocele would be when you notice a bulge, and it feels kind of like a water balloon bulging out. It's the most common type of prolapse. Next slide. Rectocele is just the opposite. It's when the rectum is the one bulging out. We see this oftentimes for people who've had constipation for a lot of years, and all that straining might cause a rectocele. Or it could be started by, let's say, an obstetric injury where as part of a delivery you had a laceration, and then the healing wasn't quite right, and then you developed a weakness there that turned into a bulge, something like that. And then there's uterine prolapse. Uterine prolapse can be partial or complete. I think the one I have here is complete. So this would be as bad as it gets, where everything's falling, not just the uterus, but the bladder and the uterus and the rectum, all of it. And obviously this would be very uncomfortable. One important thing to note is it never happens that somebody's uterus or bladder just drops out onto the floor. I get that question a lot, so I know it's on people's minds. You can have prolapse and it can bulge out, but it's never going to like literally fall out of you where something's actually, an organ's actually dropping onto the floor. Can we back up for 1 second again, please? And so the other thing is, when you're feeling this bulge, you don't really know what part is bulging out. It can be very difficult to tell on your own which part is coming out. But if you feel prolapse and you feel sort of like a water balloon in the front, that's probably the bladder. If you feel something more firm, if you're touching it, if you feel it more firm, it feels like the firmness of your nose, perhaps, that would be what the cervix or the uterus feels like. And other than pessary, we do offer surgery for these conditions. And we've got some of the greatest minimally invasive techniques. Both Dr. Saiz and myself use minimally invasive techniques, frequently incorporating robotic surgery. When you're deciding on surgery, there's different decisions to be made. One is what most people choose, which is reconstruction. And the other is something called obliterative, which is really reserved for people who are getting into their, let's say, 80s, 90s, where maintaining their sexual activity with intercourse is not on their list of priorities at all. And it's actually possible to rather than do a real invasive surgery, simply close the space of the vagina. And that's something that can be done even when patients are getting, up there quite a bit, 80s, even 90, and close that space and give them relief. And the only thing they, can't do anymore is something they, in this situation, weren't going to be doing anyway, which is having intercourse. Of course, we offer these things very carefully to patients, but it's an option. Under reconstructive surgery, there's what we call native tissue surgery, which is using the tissue that exists in your body to do the surgical repair. This often involves a vaginal approach to surgery, a vaginal hysterectomy, plus reconstruction using the connective tissue and ligaments that are right there in your pelvis. The problem with that tissue, of course, is we don't know the integrity of that tissue because it's already failed to develop the prolapse. And unfortunately, we've learned over the last 10 years especially that the failure rate from native tissue surgery is upwards of 50%. So we often incorporate graft material and next slide. Native tissue surgery is depicted here, where we're opening up the vaginal wall and then closing the tissue together to create sort of a shelf. But when that doesn't work, or sometimes we just skip right to the surgery that works the best, oftentimes actually, where we use graft augmentation, and the most common graft we use is mesh material. So the most common procedure that we would do when someone has a big enough prolapse would be called a sacrocolpopexy. So there's two images here. One has a cervix and one doesn't. So our typical way of doing this kind of surgery would be, if you have a uterus and you have a significant prolapse, we're often going to do a partial hysterectomy, which means leaving the cervix in your body, and then fastening mesh to the length of the vagina to correct the defect, and attaching the tail of the, we'll go back please, the tail of the mesh to a ligament in your pelvis. This can be done either with or without a uterus being in place. And we do it through just very small incisions on the abdomen, usually either 4 or 5 incisions. It's about a 2 to 3 hour operation. A lot of patients stay overnight in the hospital, but you don't have to. It is under general anesthesia, and it works very well. The robotic technology is fantastic. So this is actually a little video of one aspect of the surgery, just so you can get the idea. These instruments are tiny. They look a lot bigger than they really are on this image, but you can see the dexterity that we have when we're sewing the mesh into place, and it lets us be incredibly precise. And here's the view where we're attaching that other part to the level of the sacrum, which is the ligamental attachment that we use for the other end of the mesh material. And if you think this looks sort of like bloodless surgery, it really almost is. I mean, we don't lose a lot of blood in this case. It's very efficient. It's just, you know, it's major surgery, but we do it in a way that minimizes the discomfort. And so, kind of to summarize, both myself and Dr. Saiz really enjoy this field because we get to help people with their quality of life. And we have a host of surgical, non-surgical, medical, other types of treatments that either office treatments or in the operating room. And one of the best things about this field of medicine, in my opinion, is that we really get to tailor each patient's treatment to their desires and their quality of life. And we have both surgical and non-surgical treatment options for virtually everybody. So thank you. That's our presentation, but we do have some questions, I think.
Yes. So I'm going to read some of the questions without reading the names, so everybody stays comfortable sending us questions. We have a patient asking if how does she know that she's doing Kegel exercises properly? So I think one thing that we say is that if you're urinating and you're able to stop the stream in the middle of the urination, that means that you use your muscles correctly. However, we do not think that you should keep on trying this, because trying to interrupt the flow of urine is not the thing that you should be doing, but it could be a good way to determine if you're doing it correctly. Now, the best way of knowing if you're doing the exercises correctly is to go to a physical therapist where you get a proper evaluation. It's like kind of seeing a personal trainer. So the personal trainer is going to be doing internal exams, and he's going, not always, but often, he's going to tell you whether or not you're doing the exercises correctly. The next question that we have is, can the pessary be placed in the wrong place? You want to answer that one?
Sure. I try to encourage people that when it comes to that disc-shaped pessary anyway, there's no real wrong way to put it in. If it's in there, it's in there, and it's usually going to find its own position pretty close to the opening of the vagina. And so if the pessary is inside and it's relieving the symptoms, then that's going to be correct. However, we never just give someone a pessary and send them off and tell them to put it in. We do sizing ourselves, and then making sure we think it's the right size, and then teaching each patient how to not only insert it, but remove it until they feel comfortable. And then only then would you be instructed to insert it and remove it yourself on a regular basis.
We have someone asking, is the Innovo device for stress incontinence, is it effective and safe? There's a lot of talk about this. I think the marketing is great. However, I do feel that it's something helpful. I wouldn't say it doesn't hurt to try it, although I do feel that it's quite expensive. I think a better use of your time and money would be to see a physical therapist. If they find that you're having a lot of difficulty isolating the muscles and they want to use something like Innovo, they'll be the ones guiding you in how to use it and recommending this type of technology or other ones that might be cheaper.
Do you want to just remind folks what that device is? Because some people may not know.
It's basically something that is going to send electrical signals to try to stimulate the muscles contract. So it's kind of like those ads that you used to see back in the day. You put some patches and it's supposed to give you, you know, like a very fitted abdomen. And I mean, there's a use for that, but I don't think that it's the best next step. We have the next question is, do you find that estrogen cream helps overactive bladder? Do you want to answer that?
Sure. That's a tough one because there's mixed research available on that. We don't generally give it just for that reason, but we're often giving estrogen cream in the vagina as a prescription for patients who have urinary tract infections, because it's a wonderful way to prevent urinary tract infections for women who are having multiple infections per year. And it's also helpful when there's a problem with vaginal dryness. And we definitely see sometimes that people will tell us that there's an improvement in some overactive bladder symptoms, but it's not a primary treatment for that problem. It's nice when it happens, but it's not one of the go-to treatments.
They also are asking, how long does it take for Kegel exercises to eliminate stress incontinence? So eliminate is a very strong word. I think it can definitely improve your symptoms. However, I'm not certain that it could eliminate them on everyone. I think it does help, but you definitely have to give it months. It's not going to be weeks, and not everyone would see a resolution of their problems. Then we have question, is mesh safe inside the body? When I had a hernia repair, I was told mesh is no longer used. You want to take that one?
Yeah, sure. The short answer there is the mesh that we use in our surgeries is inert. It's well accepted by the human body, and it's understandable to be concerned about it because everybody's seen the commercials on TV about vaginal mesh. This is a topic where we could have a whole easily an hour-long discussion and not even cover everything. But so I'll kind of skip to the bottom line. It is that we're very fortunate to have some very lightweight, very soft mesh materials that we can use to make our prolapse operations work better. And mesh is well accepted by the body, and the gold standard approach to urinary incontinence treatment surgically is a mesh sling, and the gold standard treatment for prolapse is mesh augmentation, like I showed in those pictures with the sacral colpopexy. And so, is it safe? Absolutely.
Yeah, I think we're both have been using mesh. I could say every single week in our practice for over a decade, both of us. And if we were seeing issues, we would not be using it. I think there's a lot of propaganda in the media driven by lawyers and people trying to make money or get money out of pharmaceutical companies, unfortunately. So at the end of the day, you need to trust your doctor, thinking they're doing the right thing for me. And we both doing this for over 10 years. I think that says a lot about whether or not mesh is safe. How many surgeries for prolapse do you think you do a year?
Hundreds.
Yes.
Yeah.
Does the Kegel exercise help vaginal prolapse, specifically rectocele?
Mm. There are a few studies where when people have early prolapse, that they can, it won't solve a prolapse, it won't make it go away, but some people, when they have weak muscles and they have kind of a mild to moderate prolapse that's not bulging out very far, they can reverse that by strengthening their muscles. That is true. Rectocele is probably the most difficult one to affect with your Kegel muscles, however. You'd be more likely to have an impact on a cystocele or when the bladder is dropping.
I do find a lot of my patients that have a rectocele, the biggest issue is they have a lot of trouble emptying their bowels, because prolapse being like a hernia, there's a little pouch, and if it does involve the rectum, it's hard for all the stool to come out at once. And I find that in these patients going to physical therapy, not necessarily to just do Kegels, but to learn different techniques in helping them how to empty better, from using the squatty potty. Sometimes when you think you're pushing the right way, you're actually have a dysenergic contraction where you're tightening up the pelvic floor when you're actually supposed to relax the pelvic floor. There's a lot of improvement in defecation with physical therapy, which is not just about doing Kegels.
Very true.
How not to create a UTI from doing Kegels? I don't think they're both related in any way.
I agree. I don't think Kegel exercises will cause a UTI.
No. Can you recommend a pelvic floor physical therapist? Yes. The pelvic floor physical therapy field, the problem is that not everyone in physical therapy is trained to take care of patients that have pelvic floor issues. And a lot of the places you find out there, they actually are out of network, which is very pricey to go to these places. Now, big health organizations can afford to have a pelvic floor physical therapist that will remain in network with insurance companies. So, for example, Valley Health System does have a pelvic floor physical therapist. There are actually 3 of them, I believe now, and they are located in the MAWA, the Wellness Center. However, we have a list of other in-network physical therapy places that are also in the area. And I do give a list out to my patients, and we try to find one that is close to them. But, you know, sometimes you do have to drive a little bit to find a physical therapist that will be properly trained and that will be in your network.
Yeah, one thing I'd like to add to that, and Cristina touched on this, is if it's coming down to physical therapy for pelvic floor, it's always going to be someone who, if they're going to be good, it's all they do. So if you call and you're trying to call the office and say, do you have a pelvic floor physical therapist? The next question you should ask is this all they do? Because if that's not true, they do other things too, then they're probably not the person to see.
We have a question asking a little bit details about that sacrocolpopexy, which is the robotic repair using mesh. And they're wondering if that would also help the rectum.
Absolutely. I didn't highlight this well enough maybe on the slide, but the mesh material starts at the opening of the vagina near the rectum and goes all the way up the vagina and around and all the way down the front side. So it's supporting the rectum definitely, and supporting the vagina up at the top, and it's also supporting the bladder. So that one procedure takes care of all the defects that a person has.
We have a patient who is actually a current patient of our practice, and she's saying that the pelvic floor physical therapy exercises have been very helpful. So, you know, there it goes. They're asking, how do you deal with anal sphincter incompetence?
So I see patients with fecal incontinence. It's much more common than people realize. And it's very, very debilitating mentally and physically. And people, when they have that problem, wind up just staying home in their houses, and it's terrible. So the biggest thing to help is, or the number one thing to try is actually not something that's obvious. It's to use a product like Metamucil, or we like a liquid one called high fiber, but some kind of fiber supplement that you take to improve the bulk of the stool so that you're not having soft or liquid stools, and to try to improve the predictability. So this is something that people need to kind of experiment with on their own a little bit, but what I ask people to do initially is take a dose of the fiber with their evening meal, so at dinner time, because physiologically that tends to produce a nice firm bowel movement where you can have predictability and control and then be done with it. And so that's the kind of treatment that works for 85% of patients with fecal incontinence, honestly, is to regulate their bowel movements so that they can avoid surgery. There is surgery for fecal incontinence, but it's very much better to avoid surgery for this problem, because the surgery is a pretty rough thing to go through. And so now if someone's having bad enough fecal incontinence and they don't have any other options, sure, we'll do surgery for that, but it's a last resort. First resort is manipulating your bowel movements, make them more firm, and then sometimes we actually incorporate strategically Imodium to close down the bowel movements after you've had your morning one. So this is something we deal with.
Also, there's therapy called neuromodulation, which is a very small procedure. It's not the big surgery that Dr. Culligan was talking about. And this is a therapy that is also used for overactive bladder, and it involves using the technology of a pacemaker that gets placed under the skin in the back area so you can barely feel it, and it's going to send electrical signals to the lower aspect of your spine that is going to help you with bowel leakage and with urine leakage when it's from an overactive bladder. So that's also another promising therapy for a lot of patients.
Yeah, that's a good point. Thank you.
Does the pessary need to be removed after so much time? How many hours daily? So the pessary does need to be removed every so often. If you're not able to do it by yourself, then every 3 months, usually we have the patients come into the office and we do it for them. However, I would say that we try to teach our patients how to do it, because that will minimize discharge, that will minimize the possibility of developing an ulceration inside the vagina. So it's not safe to leave a pessary there and have no supervision for 6 months, a year. That's not okay. Unless you're able to take care of the pessary, removing it and, cleaning it by yourself. And then, once a year, then it's more than enough. What about Botox? Do you want to answer that one?
Sure. But everybody's heard of Botox, and a lot of people know how it works. Basically, anywhere you inject Botox, anywhere in your body, what it's doing is it's disassociating the nerve ending from the muscle. So if I want to get rid of these wrinkles that I have, I could have Botox injected in my forehead, and that would mean that my muscles were somewhat paralyzed, and so then they can't form the wrinkles. So it's a way to paralyze muscle groups. Sometimes it's used in the back of the neck muscles for headaches, for example. We use it in the bladder because the bladder is a muscle, and when the bladder is overactive, you can make it behave more normally by injecting it. So we both do this regularly in the office. We put a scope in the bladder and inject several areas along the wall of the bladder after we put some numbing medicine in there, so it really doesn't hurt much at all. And some people don't even feel it. And then the bladder muscle gets partially paralyzed. And that sounds bad, but it's actually good, because when you have overactive bladder and you're going to the bathroom every hour or every half an hour, it can make you have more of a normal frequency. So we do that. We usually don't start there, but we do it pretty regularly because it works very well.
Are there any side effects from putting the mesh? At what point do you need to have the mesh surgery? You want to, repeat what you explained before?
Yeah, sure. Surgery is surgery. So there's always potential problems, and we go into great detail. It's also very individualized. So everybody, when either of us are sitting down to go through surgical possibilities, we always offer a non-mesh and a mesh version and explain. And we're always explaining the potential downside. So with mesh placement, there's always a chance that the body can heal up in a way that causes a little bit of pain somewhere. Usually not in a thing that's not treatable, but that's a possibility. Also, mesh can sometimes wind up poking through the vaginal wall. We call that exposure of the mesh, or some people call it erosion of the mesh, where it becomes sort of a scratchy feeling inside the vagina. That's also possible. We have techniques to minimize these things. So we're talking about complications or issues that happen very, very small percentage of the time. Now, I wouldn't say that, well, I guess there's to answer the question directly about when do you need mesh, I think if a person's chosen to have a native tissue surgery without mesh, and then they develop a subsequent prolapse, it would almost be foolish to go try again with the same native tissue that they have and expect a different result. So I think certainly if you've had a failure of a native tissue repair, you could potentially be a great candidate for the mesh procedure we were talking about. So I think that answers that question.
We have a question. What is the typical frequency for urinating throughout the day? So that's a tricky question because it depends on the amount of fluids that you're drinking, right? If you're not drinking anything whatsoever, then, of course, you can go 3-4 hours, not making it normal, because when you go, the volume is very small. So I think that I would say a general rule of thumb, maybe 2 to 3 hours. However, if you really want to know whether or not you are urinating when you're supposed to, another way would be to measure your voids. And I would say if you're seeing anywhere north of 250 cc's, that's probably, a good sense of like, okay, my bladder was half full. If you're seeing 400 cc's, that indicates your bladder was very full, and so forth. If you're seeing 50 cc's, 100 cc's, and right there, I'm going to tell you that is not a adequate frequency of urination. It means that you're going too early. Does pelvic floor prolapse exacerbate constipation? I could see this question going both ways. So constipation exacerbates prolapse. If you have a prolapse that involves a rectocele, it could be difficult to empty your bowels. However, I don't typically see patients who have underlying constipation saying after surgery it went away, because there's a lot of factors into constipation. Is the consistency of the stool, is the way your bowel coordinates with the pelvic floor muscles, and there's so many aspects in constipation that just by me fixing the anatomy, I think it could make it better, but it's not going to resolve it, and it's not the treatment for constipation. This question goes back to the Botox. I think they did not understand if it would be a bigger problem if you try to paralyze a muscle group.
Okay. Yeah, it sounds severe when I say it that way, but so it's the injections are very precise. They're very small. And all we're trying to do is the whole bladder is a muscle. We're trying to just take little parts of the muscle and paralyze in that area. So a bladder that's overactive will sort of be normalized with the Botox injections. That's the idea. So I don't want to paralyze the whole thing, but if you do it partially, then you can have a good result. Just like if you go in for cosmetic Botox, you wouldn't want them to paralyze all the muscles in your face because you would have no expression. You want to do it just enough to get the desired result.
If you have a minor prolapse, anything you can do besides Kegels? Yes. You can control other risk factors, like if you are overweight, losing weight is extremely important. If you're constipated, trying to avoid constipation is also very important. If you have a weak core, engaging in exercises like Pilates to strengthen your core. So now this is beyond just the Kegels. That could also help. Using, pessary can also help. And then obviously surgery.
Okay, thank you both so much for your informative presentation this evening and for answering all those questions. At this